Hi everyone, good afternoon. My name is Yashaswini Singh. I have definitely seen everybody in this room before, but I haven't met everyone in this room before. So I hope that we can take this chance as a formal introduction. Specifically for those of us I haven't had a chance to say hello in person. I think we're all most of us are on the 8th floor, and so happy to chat anytime about paper research, relatively new at Brown, and you can tell. So it's great to be here. The title of my paper that I'm going to present today is Physician Professional Fees in Private Equity and Health System Affiliated Physician Practices. So I want to start out by motivating the specific questions that I look at in this paper. And then what I want to do is summarize the paper for you in 15 minutes. And then we'll take a step back. If you have any questions at that point, happy to take them, happy to answer them. But then what we'll do is we'll do a deeper dive into the data sets I use, my empirical methods. At that point, if you want to trail off, that's fine. But then I'll get deeper to the results and then close with a couple of points on why we should care about these topics. What is the policy takeaway here? Why should we as researchers be paying attention to this? But also, what is the policy significance, given that we are in the Department of Health Services and Practice? So I want to start by saying in the United States, a lot of outpatient services are provided in both hospital settings, think your traditional hospital facility, but also non-hospital settings. And what do I mean by non-hospital settings? This can take the form of physician practices, clinics that are run by physicians, where care is delivered primarily by physicians, as well as something called ambulatory surgery centers, which are outpatient centers similar to physician practices where surgeries can be provided. So think of these as a setting that might be an alternative setting to hospitals for outpatient surgeries. Now, a peculiar characteristic of pricing for outpatient services in these settings is that Medicare, the government payer for elderly over 65 years of age, pays differently for the same services depending on where care is provided. So in particular, prices for outpatient services are higher in the hospital-based settings than in non-hospital settings. Again, when I say non-hospital throughout our time today, I mean both physician practices and ASCs. So here's a summary of what researchers have found, what estimates from the Congressional Budget Office and MedPAC and other government agencies have found. Essentially, Medicare pays between 75% and over 200% more for the same services, just based on differences in site of care. Because a lot of commercial insurers in the US follow pricing set by Medicare, you have a similar price difference across site of care, even within commercially insured populations. So I have summary that shows commercially insured services are reimbursed more than double, so 145% more if they are provided in a hospital setting compared to the same set of services provided in non-hospital settings. And of course, this translates into higher costs for patients as well, who often face differences in out-of-pocket payments based on where the care is received. Now, you might think hospital-based prices are higher because hospitals might be delivering higher quality care or might be seeing more complex patients and so on. But again, a large body of work has looked at this and shown that even as for differences in patient risk, or differences in the quality of care delivered, you don't tend to see too many differences across settings, and the price differences persist, is the bottom line. So naturally, so this is an illustration of what that means in practice and why prices are higher in hospital settings. So this is a snapshot of Medicare prices for just one type of service, colonoscopy, PPT code 45378. And the key reason why prices are higher at hospital-based settings is the inclusion of something called a facility fee. Now, prices can be decomposed in general to a facility component and a professional component. Think of the physician fee or the doctor fee or the professional fee as the price paid for physicians, price paid to physicians for their services. And think of the facility fee as the portion of price that is paid for the hospital to cover its costs, to maintain capacity. It's really something that goes to the facility rather than professional delivering care. Now, Medicare policy allows facility fees to be charged more at hospitals, and you see this translates into almost to 300 different jobs coming from facility fee for the same service, again, provided at 2 different settings of care.
Can we think of this as like variation in indirect rates across another colleges?
Sure. So naturally, these differences in prices have led to a lot of policy debate and concern and momentum to understand why prices are higher at some settings if we're not getting the same quality. A lot of this policy focus has been on hospital-based prices, rightly so, based on the last slide. And the emphasis has been in particular on regulating facility fees as a way to control overall healthcare prices or overall healthcare spending. I have some screenshots of news articles and government reports from the last year or two. In particular, states are really leading the charge here. You've seen New York, Connecticut, Oregon, and others introduce bills and pass bills that look specifically to regulating facility fees as a way of slowing hospital-based spending. Chris.
I think about the state facility fee legislation law that stories around facility fees for professional-based services versus what drives a lot of the Medicare and commercial side of care differential is there's still facility implications. It's just it's much larger facility fee.
Yes, absolutely. And I think we can see that well here. So importantly, ASCs and other settings, and let me know if this gets to your point, they still have an ability to add a facility fee, as we see here, 474 facility fees, 178 in professional fees, coming to a total of 521 if you get a colonoscopy in an ASC. And similarly, 178 professional fee in the hospital setting, but check this out, 870 compared to 474 just as differences in facility fees. And so the point here I'm trying to make is people are concerned, people are paying attention, and a lot of this concern and attention has taken the form of legislation to control facility fees as a way to slow down healthcare spending. So that's great. So why do I have a whole paper on this, right? So it's great you have a problem, you have legislation in place to address some of it. I want to introduce another layer of the problem to you before I get to my paper. So at the same time, while you have momentum to regulate facility fees and shift care away from hospital-based settings to non-hospital settings, we've seen a massive increase in the acquisitions of these non-hospital settings by private equity firms. Anyone who's ever talked to me about private equity knows that this is an area that I've spent a lot of my time thinking about and working on. So I want to take a minute to set the stage so that we're on the same page as to what private equity is, what its incentives are, and why we should be concerned about it as perhaps an alternate form of consolidation, different from hospital-based consolidation. So again, taking a step back, bear with me if this is all familiar to you, but there are a lot of new faces here, so I want to make sure that we're all on the same starting page here. So private equity in general refers to an alternate form of investment where PE firms raise capital from limited partners. These are university endowments, they can be pension funds, high net worth individuals, and so on. And then they combine this equity or capital with a lot of debt that's raised from lenders, banks, or other private equity firms. Now, typically, this PE fund that is set up by the PE firm is a combination of both capital that comes from limited partners, but also, as I mentioned, a large amount of debt. And the amount of debt is often upwards of 60 to 90%. And so the investment vehicle really is one of debt. So traditionally, they're called leveraged buyouts because of the large share of debt involved in these transactions. This fund is then used as an to make a majority investment in what I call here, for illustrative purposes, a platform practice. Now, this is a practice that has great brand recognition, might have a loyal stream of patients, established market share. In this example, it's a practice of 3 physicians in a market. Now, depending on state regulation, PE firms might make this acquisition through a management services organization. This is just for your reference. It's not really related to this paper that I'm presenting today. But anyway, you have PE firms taking a platform acquisition. And then of note, in the physician practice setting, the private equity growth strategy is one of consolidation. So after you have an acquisition of a platform practice, PE firms will gradually increase market share by undertaking what are called roll-up acquisitions of smaller practices. So you have roll-up of 2 practices, another acquisition of one physician, another acquisition of 4 physicians, and then suddenly you're in a setting where you have one firm that employs 10 physicians in a market, even though each individual acquisition was just a handful of fearful physicians per practice. So this type of roll-up consolidation strategy allows private equity firms to, 1, increase market share, 2, leverage economies of scale, but also 3, importantly for the PE investors, it allows them to capitalize on size as a way of increasing the valuation of the practice upon exit. And what does exit look like? Again, from finance and the investment sort of industry literature, we know that exit can take the form of 3 potential paths. You could have private equity firms listing the platform practice on a public stock exchange for the first time, so an IPO, or PE firms can sell the practice to another PE firm, which in physician practices seems to be the dominant exit strategy, or you can have PE firms selling to a corporate investor. In healthcare, this might take the form of a hospital system or an entity-based doctor. So I laid this out here, 1, to get to PE's incentives. 1, the incentives are to quickly generate firm value and exit. Typically, exit is in 3 to 7 years. Again, we have some work that shows it's actually on the shorter end of the timeline. It's in 3 years in physician practices. But also, I laid this out here to emphasize this part of the growth strategy in physician practices. The PE strategy in physician practices is one of consolidation. And so if we look back to what we know from all of the research and consolidation in healthcare markets, we expect this to increase prices. So again, going back to
We're still required to look at that. So is there any research that has to look at those households or the reasons why this initial platform practice sell their practice to the PE firm? Yeah. What kind of the deal do they get?
So questions around why physicians choose to partner with PE, I think, are very important, but there's so much secrecy around these acquisitions, NDAs, gag clauses, and so on, that there's very little that we can get researchers. I will tell you from conversations with physicians, money is a big motivator. I think I mentioned this to a subset of people in this group, but the price that one physician got for a solo practice of just one physician was $8 million. And so I think as we see a generational shift with older physicians sort of done with the administrative burden of being the sole proprietor, and then younger physicians who may or may not have aspirations to be the partner one day, they want better work-life balance and autonomy. Many physicians see PE as a better alternative to office employment. So confluence of factors, but very difficult to study empirically. So I want to get us back to, the trend that I laid out in the beginning. On the one hand, you have hospital-based spending, in part due to high facility fees, driving up the total cost of care. And this is prompting a lot of policymakers to consider proposals that would shift care from the hospital to the non-hospital setting. At the same time, you have a lot of these non-hospital settings being acquired by private equity firms that have also been documented to help their cases. So really then the key policy question that's motivated this work is, if we look at these outpatient practices that are acquired by PE firms, do they remain lower price alternatives to health systems after acquisition, or is PE eroding that price advantage that we've known outpatient settings to have relative to health systems? I can restate that policy question as a specific measurable research question, and that's what I look at in this paper. So in this paper, what I set out to examine is the impact of PE acquisitions of outpatient practices relative to health system outpatient practices. Now, if we think of health systems or hospital systems, because we're in the setting of outpatient services and outpatient facilities, what I really mean is comparing 2 types of settings that look very comparable. So we're not really looking at inpatient hospital gastroenterology care, comparing it to outpatient. These are both outpatient clinics. The only difference is one has the branding of a hospital system outside, and the other has branding of a PE platform, GI Alliance outside. So again, we're in the outpatient setting. We're comparing outpatient services. We're comparing prices for outpatient services. And thanks to our data, we can look at professional and facility fees separately to see, one, if anything's changing, two, what is the source of change. So really quickly, I'm going to tell you about the clinical setting we're in before I summarize my paper. So the setting we're in is gastroenterology, as might have been included in the paper title, I can't recall. But let me tell you why this is a clinical setting. So first, gastroenterology is a setting where we've seen a rapid increase in vertical integration of health systems and physician practices. The share of physicians that are employed by health systems has increased about 12 percentage points from 26 to 38% between, say, the last decade or so. And then at the same time, we've seen gastroenterology go from really 0% to 7% by 2019. And this is a paper from this past January, where it estimated between 2019 and 2024, the share of gastroenterology physicians in PE has doubled. And so this is not a trend that's slowing down. Does it compare with health system affiliation of gastroenterologists? I think, we're lacking data that lets us make that one-to-one comparison. But regardless, the point is this is a setting where you have a large share of physicians employed by hospitals and an equally or emerging large share employed by PE firms. And importantly, as I mentioned in response to Pedro's question earlier, a lot of physicians, gastroenterologists in particular, perceive employment by private equity firms as being a favorable alternative to employment by health systems. This can be because of a variety of reasons. A lot of physicians perceive hospitals to be this sort of big bureaucratic institution where you really lose your own autonomy. In contrast, they see private equity firms as being their financing partner. A lot of PE firms will still advertise on their websites, we're still wholly physician-led and physician-owned. We're just financing the physician practices, which again, legally might be accurate, but we have now a growing body of research that shows there are changes to practice patterns that emerge from acquisition, suggesting that independence isn't quite the same meaning for everybody involved. So again, a quick summary of my data before I share with you my results. I put together a lot of data for this paper. In some, I get data on private equity ownership from a financial database called PitchBook, and I supplement this with a lot of hand-collected data from press releases, industry reports, and websites. Spent many years while I was doing that. And then I collected data on health system affiliation from data sets from IQVIA, which is physician registry of physicians in the US. And then finally, I construct my outcomes of interest, measure the prices and utilization at the practice level using Fair Health commercial claims database.
So in this setting, you might have mentioned it earlier, but is it the management services organizations that actually do the operational stuff, or it's private equity that have more influence in that?
Excellent question. The short answer is the data is so terrible, we can't differentiate between outright investment by a firm versus something that goes through a management services organization. So we treat everything that has that kind of investing or investment as PE acquired, but to highlight some of the challenges with doing work in this space, because there's a lot of heterogeneity in what we consider PE. So I guess this is a side note. For all research in private equity, anything that anyone ever shares with you is the average effect of the average PE firm on the average position, and anything take that several layers down because we're just lacking data. So transitioning to my empirical approach here, I combine matching with differences and differences. The reason why I use a little bit of matching is because of this idea that acquisitions don't happen at random. And so if you compare all acquired practices to everything that's non-acquired, it's hard to say which practices were acquired because they were systematically different from the non-acquired practices. So the goal of the matching exercise is to construct a matched control data set that, at least on the basis of observables, looks randomly different from PE acquired practices in the year prior to any acquisition. And then we have our standard event study design. Identification comes from variation in timing of acquisition, which you can see here. I should have mentioned when we were on this slide, I have 126 acquisitions in the last 4 years or so. I guess it's 8 years now. But a lot of the acquisitions picked up starting 2018. But importantly, there's variation in timing of acquisition, but also I'm able to link acquisition data to claims data before acquisition. So I can observe the outcomes of interest both at acquired practices and matched controls before and after acquisition. So that's great. Okay, so my paper in a figure is this event study plot here. So this figure summarizes results from an event study regression that looks at a measure of price, so allowed amount per claim. After acquisition, on the horizontal axis, we have quarters relative to acquisition, and on the vertical axis, we have prices. And so this tells us, basically, to summarize the entire paper on this slide, we find after acquisition, prices increase by about 19%. And all of this comes from increase in professional. There are no changes to facility fees. All of the PE-driven price increases are from changes to professional fees. We also see some changes in patient utilization, and then we look at somewhat crude measures of patient risk. That's the best that's available, and there we see no changes in patient risk. Yes, Chief.
This is such an amazing figure. Just great, tell the story right there. I guess what's really odd to me is that if insurers were potentially willing and able to pay higher prices, why didn't these independent practices get that before? Were they insufficiently sophisticated?
The answer to that question is here. So before acquisition, you had, this one solo practitioner trying to negotiate with the cost, and it's hard to bring the same negotiating leverage to the table, but you have a setting of 10 practices negotiating together across state lines, across specialties, and that gives you a lot of bargaining power. Yes. Those physicians salary, how much of that margin do they get? So we feel states fit. I would love to get my hands on data that helps me understand how much of it trickles down to the workforce, right? Or how much of it is translated into improvements that shape care delivery. We don't really have data on that, but the first part of your question, do they become employees? Yes, they become salaried employees and retain some minority share. And that's how the firms are able to align incentives between investors and physicians, because if you are not committed to growing the practice, you lose out financially. And then you also have non-competes that lock you in. So not a great situation as well. And
are there any facility fees that are being generated by these PE acquired practices?
Are there any facility fees generated?
At all?
So there are, and it's because both health systems and PE firms in gastroenterology own offices as well as ASCs. And so in this paper, we don't have data to figure out where the facility fees are coming from, but I suspect it's coming from joint ownership of ASCs.
Yes. Okay.
If a physician or gastroenterologist does like a colonoscopy in a physician office, which is like 3 or so percent, do they still get the facility fee for that, or is it just entirely collection fee?
So I don't have that granularity in this data set to take a look at what services are being billed and where facility fees are coming from. But I think at HCC I would do that. Yes, and the last question, and then I want to back up. I'm just curious in terms of the increase in prices. Are you seeing that it's a change in the type of services, like more colonoscopies with polyps or that kind of a thing, that shift of like the types of codes being used, I guess, that are higher reimbursement rates? Yeah, that's a great question. And also one of the limitations of this work is because the Fair Health claims data we use for outcomes is de-identified, we're unable to take a deeper look into, is it service mix? Is it site of care differential? Are you just shifting everything to an ASC and that's how you're getting higher prices? Or are you doing, higher E&M visits, for example? Those are all great questions, but unfortunately, I don't have the ability to look at that with ACF. So I'll keep moving. I want to lay out sort of where this paper sits or fits in, the context of literature around similar topics. And so some of this we already talked about, but there's a large body of work that shows a site-based payment differential for the same services, really for patients with the same risk conditions and similar quality of care. Hospital-based services are more expensive, and a lot of this has to do with facility fees. And then also, we've talked about this already, but a large share of these outpatient practices that hospital-based care is being shifted to is now owned by PE firms. And again, we know from other settings compared to independent practices, PE firms increase prices. And so this paper takes all of this literature here and makes these two unique contributions. Right? The first is I take a look at PE acquired practices and I compare them to the counterfactual of health system practices. It's a particularly important counterfactual in the setting of gastroenterology, given the trends I showed you earlier and perceptions that physicians have of alternate employment choices. And then finally, with respect to the policy significance here, there's a lot of debate around how do we make healthcare more affordable? How do we regulate prices? Which prices do we regulate? And this paper speaks to some of those concerns. Importantly, because a lot of the emphasis has been on facility fees, this paper shows, perhaps we need to take an approach that is focused more on the total cost of care, given that you have, on the one hand, increasing involvement of PE firms in outpatient settings, but also two, this new finding that the price increases come from professional fees and not facility fees. So it's kind of like the game of whack-a-mole, where if you only go after facility fees, you're missing out on this unchecked spending growth that's coming from professional fees. So that's my paper. I think I have 30 minutes to get into the details, but are there any questions I can clarify at this point?
This is a quick question about the control group of health system affiliated or owned practices, not just affiliated practices. They're like formally owned, right?
A mix of both.
Mix of both. Okay, that's interesting. I'd be interested to know if you made two counterfactual groups like formally tied health systems, and which I think would be more comparable versus like the informally tied, affiliates. But I was also wondering, are they matched? Are you matching to practices that were acquired by the health system, or which is always affiliated?
Yeah, great point of clarification. Thank you for that. So my control group, and maybe we can transition to the next section here with this question. My control group is made up of practices that were always affiliated with health systems, right? So the important distinction is you have the acquisition effect and you have the private equity effect. So to get at the private equity effect, I would compare PE acquired practices to practices that were acquired by health systems.
Yeah.
But we don't have data on new acquisitions by health systems of physician practices. What I have instead is data on affiliations and ownership, but it's not time variant. It's constant over time. And so in some ways that helps me because my control group is experiencing its own time varying changes differently than PE practices, but it doesn't get to the question of, is this a PE effect?
Thank you.
Yes.
It's a kind of general question. Now the point of my dissertation, I'm thinking about prices, but are those price figures, is it standard practice to adjust for consumer price index at all? Or is it like?
I haven't seen that. I would say you're in an event study. Yeah, well, fixed effective therapy, but also difference in differences if you're comparing practices sort of at the same point in time that you are here. I would assume that gets different out. That would be interesting about it. Okay, I want to keep moving. If that's okay, Chris. I'll take your question.
So I this question building on Cyrus. So how should we think of the two competing forms of consolidation? So PE here and hospitals here, and so this 35% increase in professional fees. What is that in absolute dollars?
Oh, I have that coming up. So I believe it's $90 per plate.
Okay, so that might be backing out what's tied to the first slide on the $203 difference facility fee side.
No, but the rate.
PE, it's a third of the effective hospital acquisitions.
That's a real great. Thank you for that. All right, so as I promised, I'm going to spend a little bit more time getting into the weeds of my data construction and my empirical approach, although we've started to wade in that direction, so that's great. I get acquisition data from PitchBook. It's a financial database that tracks mergers and acquisitions across industries. It has data on names of acquired entities, timing of acquisition, location, although it tends to be the headquarters of the actual clinic locations, and then also financing status means, the PE backed, the VC backed, so on. I link that, or I should say, what is missing here is data on the physicians who are located at these practices. And I need that data to link to outcomes. And so I get around that issue by making an intermediate data linkage. I link data to IQVIA, which again includes information on physician national provider identifiers, the location of practices where physicians practice, and the ownership type, whether or not you're affiliated with the health system. And then because I link that to PageBook, I'm able to see whether or not you're acquired by private equity. And then finally, I construct claims or outcomes of interest that span various measures of price and utilization to get at the question of differential change. Importantly, because Fair Health does not allow access to claim level data, it's de-identified and aggregated at the practice level. So all of the exciting questions that we were talking about a few minutes ago, unfortunately, I don't have the ability to take a stab at them in this paper. So what I miss out, ultimately, if you compare this slide and the next slide, is data on location of acquired practices and these specific physicians. It's all aggregated up to the practice level and then mapped so that, any interesting questions around service mix or geographic patterns and so on were limited here in that respect. So this again goes to some of the themes that we've begun to talk about. How do I specifically go about estimating these results? So I use a mass differences design. I compare 3 match controls to every 1 PE acquired practice. And to identify my match controls, we test a whole variety of things. But what I present today in our trade together is the specification that matches on size of the market they are in, and then within 1 standard deviation of some continuous covariates, things such as patient volume, service volume, to get baseline size. And then this is my, if you're looking for numbers and Greek letters, that's the equation I estimate. I have fixed effects for the matched cohort. And so a cohort is 1 PE acquired practice and 3 matched controls. And then also time, and then in sort of different iterations, the 40 pages on the appendix, there are different versions of fixed effects and so on. So I'd be happy to share that with you if you'd like to take a closer look. All right. So because I rely on matching to construct my match controls, I need to show you that matching actually is something that's here. And what we see here on this table is baseline attributes of PE acquired and health system affiliated practices before and after matching. There's a lot of numbers, but I'll just draw your attention to these boxes here. These are the dimensions along which, again, observable dimensions along which PE practices differ from health systems. So you have, average prices, professional fees, and patient risk differing at health systems. Understandably, you might expect hospitals or health system practices to see patients that are, higher risk than other settings. But then after matching, you see, we do a better job of trying to come up with an apples to apples comparison. So any significant differences between the 2 groups disappear. Unfortunately, we lose a little bit of sample size going from 149 as far as practices to 126, but it's a trade-off between precision, which we're able to get here because we're comparing controls that are more alike PE. All right, so this should look similar to the previous slide, but what we find is, and I'll go through the next couple of slides quickly because the format of the graph is all the same. On the horizontal axis, you have quarter since acquisition, and then I'm going to measure for the prices in dollars, and then for measures of utilization, it's number of patients. And so really quickly, we see allowed amounts per claim increase by $90, which translates to a 19% increase over baseline. All of these results are significant at the 1%. As I mentioned earlier, again, a lot of this increase is coming from increases in professional fees that increased by $172 or 35% over baseline. Aggregated across all post-acquisition quarters, we don't see any changes to facility fees, although there's some some interesting variation happening here, which suggests that the questions that came earlier about, where are the facility fees coming from? Is it a mix in services provided or settings where care is delivered? This figure suggests we need to take a closer look into sources of facility fees. But anyhow, in this setting, we don't see any significant changes. I also look at some secondary outcomes here. We look at charge master prices and find charges increased by a lot as well. So PE acquired practices increased prices by about, or charge prices by about $180, which translates into 16%. And then because a lot of the emphasis on PE is on growth and practice expansion, it's of no surprise that we also see patient visits increase. So you see 25 patients per quarter more, which translates into 22% over baseline. And then with respect to questions around changing patient composition, we have data on ATC scores. So we take a look to see if those change over time. And again, we don't see any changes there.
For the utilization slide in the previous one, how is it a 25 patient increase if the post-period average is less than 10 and the pre is around 5?
So the numbers in this box are from the difference in differences.
You think it'd be the average of the pre?
It should. Yeah, it should. I can take a closer look. Let's see.
Are you able to observe the extent to which practices are going out of network? Do you participating?
Not for this paper. No. I do have some data on that, but not specifically for this. My sense also is a lot of the out-of-network strategy is limited to radiology and anesthesia and emergency medicine. I haven't heard as much of that as being a revenue play in gastroenterology. David?
You have information on the payer mix of the practice?
No. I am getting data that would help me look at payer mix changes in the state of Florida, which is number one in all specialties for PE investments, but this is just limited to commercial insurers.
For both referral, the charges, professional and facility fee figures, it looks like there's like a slight increase kind of right after quarter four, it jumps up again. How much do you think is that like the contracting cycle basically wrapping? So maybe there's some slight increase where there's a management change, but that renegotiated contracts, that's really when the full force of the contracted power comes from.
Yeah, that's a great point. I think that is part of the story. I think the other part is a lot of these acquisitions happened fairly recently, so 2017, 2018 onwards, and we only have claims through 2020. And so we don't have enough quarters of follow-up data for all acquisition years. And I think whatever trends we're seeing in the later quarters comes from that changing mix of practices that we're able to observe.
Some good questions. So if they're charging more, how is it that they're able to acquire patients? You would think that insurance companies don't run away from these guys that are charging more.
Yeah, that's a great question. So we don't know how they're doing it, which kind of highlights all of the gaps in understanding mechanisms behind a lot of these trends. Again, anecdotally, there's an emphasis on branding and marketing. And so in certain areas of Texas where you see a lot of PE, every billboard is of a PE acquired city. So, we have expanded hours of operation. Come see us. We have a fancier lobby. We'll serve you, I don't know, bubble tea in the lobby.
So I was wondering if, given that their strategy is to keep adding to the practice, where is that what you're seeing here? Are you saying, okay, the biggest, these are the physicians in this firm, we're going to call that the treatment group throughout? Or are you modifying the treatment group depending on these new acquisitions over the post period?
Yes, thank you for that clarifying question. So that's a very important point. What I didn't mention, and I should have mentioned, is to get around that concern, to figure out whether the changes are coming from expansion or consolidation. What we do is we fix the number of physicians to only those who are in the practice before acquisition and after acquisition. And we do that because, one, entrance might be different from stayers, it might be different from exiters. And so you want to isolate very cleanly what is the change coming from just the physicians who stay. But also, two, this figure here suggests that this does not reflect the expansion that we were talking about a minute ago, because you're still holding the physician workforce the same. to pre-acquisition levels, but maybe you're just increasing the pressures physicians face to see more patients over time, over days. So instead of spending, 1 hour with 10 patients a day, you're spending 15 minutes with 45 patients.
Some of the data was at the clinic. So the composition of physicians within the clinic changes because one leaves or they add an extra one. Are you able to capture that?
We are not, because we restricted to physicians who stay, and so we assume there are no changes, and then the data is identified and aggregated. So because we knew that the aggregation was coming up based on our Fair Health contract, we decided to make that sort of sample definition assumption.
But like kind of working on Hannah's point about why is this increasing over time? Maybe there's like this kind of unobserved growth in market power that's occurring as a result of the roll-up. Even though you're fixing that acquired clinic, that where the negotiating power of that clinic is increasing with additional roll-ups.
Absolutely. I couldn't agree more. It's a limitation of what we observe, but that doesn't mean that's not happening. And, to the extent you're able to leverage that increase in market power to negotiate higher rates, that would be consistent with what we see here. We're just not able to tell in our data which practices tie back to the same parent PE firm. We are collecting data on that at present, and so hopefully any future iterations of that work will be able to take that.
Could it be that they're stealing patients from the other practices in the area?
Yes. All of this is definitely possible and consistent with the aggressive growth and consolidation strategy. I can't emphasize enough how challenging it is to get data on these. And so this is really the tip of the iceberg, but with more granular data that sort of collects all of these nuances in practice patterns that might change, hopefully we'll be able to answer those questions. Yes, but
And sorry to ask you another,
no, please don't.
why don't you have a question? What about that? You look at like the number of visits, like encounters as opposed to like patients, and it is more broadly, it's like delivery of care, like your second act.
So I don't look at that in this paper, but I do have a paper that looks at that, and we see encounters increase. So you're seeing more patients, you're doing more stuff to the patients you see. And then we look at ENF or duration of office visits for those patients, and we see that you're also doing longer evaluation visits for those patients. And yet you're holding the physicians the same. So I'm not sure.
I want to like connect that to the HCC result. But I think that if you see like an increase in encounters, you can explain why you're not really seeing a change at HCC. A change at HCC would happen if you see like a bunch of patients. Probably if you have the same patients getting more encounters. Like I think that just what ends up happening here at HCC is.
Yeah. So what's in the paper, but not part of this presentation, is you have an increase in the number of unique patients, but a lot of that comes from new patients. And so to Cyrus's point, it's not just that you're seeing the same patients, but doing more to them. You're seeing the same patients, you're doing more to them from my other papers, but you're also seeing a lot of new patients. And so it's hard to disentangle them how we should be thinking about these collectively. So I want to take this chance to summarize the last 10 minutes of our conversation to say the study has limitations, right? The data have limitations. A lot of it is not, it's something that's not visible to researchers, but it's also not something that's visible to policymakers and regulators. So we've talked about, I think, most of these. Again, I'll acknowledge and emphasize some in particular. One, there's a lot of error in identifying PE acquisitions. So these are private by nature. There are no reporting or disclosure requirements. And up until recently, the first private equity paper I wrote, there were no private equity papers. And so we're now at a time where there's renewed focus on PE as a new wave of consolidation. So hopefully, that suggests better data in the years to come. Second, again, to Cyrus's point, there's a lot of error in identifying health system affiliation as well. The FTC is doing lots more about this than private equity at present. And I'm hopeful that we'll, with the years to come, have better data on identifying separately outright ownership, as Cyrus mentioned, differently from strategic affiliations or joint ventures and so on. And so at present, we're grouping in potentially heterogeneous entities such as direct ownership and affiliations, but also nonprofits, for-profits, academic, medical centers, or outpatient settings affiliated with them, and so on. And so there's a lot of room for refinement and improvement here. And then finally, this is really the thorn in all of this is, I think I have what is a really interesting finding here, but it's not really that interesting if I can't tell you the specific mechanisms behind increases in professional fees. So this is something that I'm collecting data on at present, and hopefully, if I come out for a talk, take the elevator down to this floor from the 8th floor, in a couple of months, I'll be able to tell you what services are driving changes to prices, if there are inside of care differences, if it's a market power story or a service intensity story, and so on. But regardless, there's a signal here that a lot is changing, and a lot of that is focused on higher prices and higher professional fees after PE. So even if we can't look under the hood to see what exactly is driving higher prices, there's enough of a signal here that tells us we should be thinking about PE consolidation of outpatient practices, a little distinct from civilized physicians traditionally in this space. And also, if I give you enough reasons to doubt this paper, I'll give you enough reasons to take my results here at face value. So we do a lot of different sensitivity and specification and robustness tests. They're all in the paper, and results hold up to all of these different assessments. And so, take that for what you will. But maybe here, in the last 10 minutes, I'll conclude with this slide, and happy to take more questions. But I want to emphasize here that in the physician practice space, there's been a lot of consolidation activity in the past 5 years in particular. Traditionally, since the 2010s, a lot of this consolidation was led by health systems, which led to higher prices through facility fees. In the last 5 years, though, 70% of acquisitions of physician practices have been by PE firms, and these have all been concentrated in the outpatient setting. And so questions around, what does this mean for policy efforts to promote the affordability of care, I think are especially important now more so than ever, because you have different mechanisms of increasing prices. And this paper shows that some of the mechanisms are different depending on who owns your physician practice. So why don't I wrap up here and see if there are any clarifying questions or directions for future research or just general reflections folks might have to share with.
I think it's not works.
You're able to look at the non-PE firms that are listed in those markets. So is I guess one of the things is the increase in prices isn't driven by their own increases, or is it that the other guys are lowering their prices, and so their initial looks bigger? Or are they both moving in the same direction? Oh, now that these guys are charging 200 instead of 100, I'll charge 150, and I'll look like I'm getting you a great deal, even though I'm charging you 50% more.
So in the paper, I have unadjusted trends of my outcomes to see just the raw data. Are there any trends worth picking apart? And for both independent practices and health system practices, everything pretty much stays.
That's fine.
Alyssa has a question. Mine.
Thank you, Chris. Alyssa, feel free to unmute yourself. I don't know how to.
Oh, awesome. Can you hear?
Yes.
Awesome. So first of all, super awesome paper. Really interesting to hear. I have one technical question and one high level question, and feel free to talk about either now or neither, depending on timing. So I was wondering first on the event study plots that you showed in the longer presentation of results. A lot of them seem to have coefficients in the pre-period that were not centered around 0. And I was wondering how you thought about interpreting those and any adjustments or bounding done sort of related to non-zero pre-trends. And then the second question I had was, I think you addressed it a little bit here, but it does feel like a lot of price regulation can easily feel like whack-a-mole, where you can regulate facility fees and then they say, let's raise physician fees. Other than focusing on the total cost of care, do you have any thoughts for reducing the potential for feeling like whack-a-mole with price regulations?
Thank you. So the first question, I won't try and go back to the slide, but essentially in the pre-acquisition period, we don't see no difference between PE and controlled practices. In fact, we see for the pricing outcomes, maybe it's easier to just go back to the slide. For the pricing outcomes, prices are lower than hospital-acquired practices before acquisition. So I thought that was an interesting finding to present rather than doing some adjustment or correction around it. Just the fact that, look, he targets a firm, increases prices, but what happens to those firms before acquisition? They're really underpriced relative to hospital systems. And that's consistent with what I've heard from speaking with physicians is the pitch that's made by PE firms, the PE investors to physician practices, and look at the big bad hospital guys negotiating high prices. Come join us. We will help you negotiate with them and compete with them. Why should you get underpaid? And so, to me, looking at this figure, I sort of sense that story in these pre-acquisition coefficients. But I will admit, I would love to chat offline about potential adjustments you might consider and how that might change results.
I think this comes where the reference period is -7 instead of -1. And I think you had the process that if you change it to -1, the reference period and 6 are same. So it's just a question. We can't observe what happens between 7 and 6.
So what is?
So I think T-7 is the reference period that falls out. And
Okay.
Yeah, and so I think that was
Yeah, so I have a version in the appendix that goes to T-8, which is as far as we can go back and we kind of see the same trends here and similar trends here, but with larger standard errors. But Alyssa, if that doesn't speak to your question, please let me know, or we can set a recording too.
That's super helpful. Thanks.
That like there's an effect at the time of treatment at like basically like the trend looks good up until the immediate period preceding the PD acquisition. Like a study is telling me that there's something right at the the introduction of those like the immediate preceding. So here is 0 is still 3 or
So 0 in this graph is the washout period. It's the quarter of acquisition. And then I have done other versions that use the quarter before acquisition at the reference period. I will say, though, that there's a lot of measurement error in identifying the timing of acquisition. And so often what we rely on is a disclosed press release, but that could come months after the transaction closed. And so how folks get around that is fine. You take the entire quarter around when the disclosure was made and you treat that in 0 or 1 period.
okay. So then this difference here, is this just the difference, like the unstandardized difference in Y, or is it a difference relative to how the event study, we set the difference to 0 in like the
latter.
Yeah. Okay.
So these are all from the sheets.
And in which case there's no problem. Like there's no issue with parallel trends. Just like a difference in levels that's turning out.
Also, I had another question about policy efforts, if you can categorize it as such, how to avoid playing whack-a-mole. I don't know that I have the solution here, but there's a toolkit at disposal here. Price regulation is one aspect of it. A lot of the recent momentum has been on the antitrust and competition side from the federal authorities, but also your state attorneys general offices. And then finally, I'll go back to my last slide here. Anyone who's spent even a minute talking to me about these topics knows that ownership transparency is something that you cannot emphasize enough. At present, if you want to know if a hospital owns your doctor's office or a private equity firm does, or a retail investor like Walmart or CVS does, there's really no way for patients to know, but also researchers to know, and shockingly for policymakers and regulators to know. So ownership transparency is really an essential stepping stone and foundation that would allow us to have a better understanding of these things.
It sounds like their power comes by acquiring and growing. Otherwise, if they don't have enough size, they cannot market. So that would be the policy. The first thing that I would do if I were the policy here is to restrict how much consolidation there is in the market for things that are right for increasing prices. It will limit it once you can control.
I absolutely agree with that. Yeah, Khan, I'm so pleased with that.
As a softball end, you talk about lots of different types of data. Like, right, like so much of the conversation is about what types of data does books. And so there was one particular kind of set of data points that you could have, one particular variable that could exist that you think would really help you understand this picture better. What would be the one thing that you're most excited about?
Yeah, thank you for that. I would say this bottom line here. So, having infrastructure in place to track changes in ownership is essential. We have it in an imperfect way, but we have it for nursing homes, we have it for hospitals. In the physician practice space, it's really unregulated, in part because they're so fragmented. How do you do it in a way that reduces the burden for physicians to having to make those reporting requirements? But there has to be a better way for us to know ownership changes, because we're only going to see more of it moving forward. It's not going to slow down. And so now it's time to stop and reflect and see what we can do with respect to ownership transparency. And I'm happy to see that there's been a lot of bipartisan interest in introducing legislation that would do exactly that. The nuances all differ across specific types of legislation, but there's a lot of attention and a lot of interest in tackling this. Okay. Well, thank you, everybody.